So I'm going to talk about some work that we have been doing looking at stone volume. So how many of you have been on call and the ER calls you and they say, we have a patient in the ER, he has flank pains, nausea, vomiting, he's formed stones in the past. What do you want to do about him? And here's his CAT scan. And you can imagine if you have the patient on the left versus the patient on the right, there's probably a very different way you might be thinking about managing them. So the patient on the left has a 19 millimeter proximal ureteral stone. The patient on the right has a 3 millimeter ureteral stone. What's worse is it's possible that the ER physician may not even look at the CAT scan. They may read the report. And the report on the left, which has happened to me, may even call this an 8 millimeter stone, depending on what view the radiologist is looking at, if it's the axial slice. So you can see that even from this one, how you measure the stone, how you think about it, can be really important in affecting your management decisions. And so I would argue in this case, certainly this, volume may be a more important tool here than just one linear dimension. So we know that if we're thinking about, the course of a ureteral stone and spontaneous passage, predicting the likelihood of that stone passing to date has really been dependent on stone size, or I like to think of it as stone burden. And stone burden can also aid in surgical planning. So if you have a large stone versus a small stone, are you thinking ureteroscopy and dusting? Are you thinking maybe you need a PCNL? There's a lot of subtleties. The classic one I do a lot of PCNLs, you might get a staghorn calculus that's 1.2 centimeters. So then in your mind, if I see that report from an outside hospital, I don't know, is that one dimension that the radiologist saw? Maybe it's actually a 4 centimeter stone and they got a cross section, or maybe it's truly only 1.2 centimeters, in which case I think labeling it staghorn is a separate problem, but I could be more amenable for ureteroscopy. So the guidelines do suggest using stone burden in our decision making, and currently linear dimension is kind of the standard. But you can see in this picture, for example, both of these stones have the same linear dimension of 2.4 millimeters, but their volume varies by threefold. So if you're going to try to predict outcomes after ureteroscopy, for example, and you're predicting operative times, we're starting a pilot program using stone volume to predict how to book our case times. So if I have a day lined up of this kind of stone versus this kind of stone, I'm going to be able to do a lot fewer cases. Yet right now the operating room books the same amount of time per case. And then furthermore, we talked about variation in radiology readings. So I was wandering around when I was first here a few days ago. I was hoping to get some pictures of snow structures to illustrate this point, and I failed in that mission. So the best I could do is I found some objects around my hotel room to illustrate this point. So bear with me. But you can imagine if you have these three objects, on the pillow on the left versus the pillow in the middle versus the towel, right? Those are clearly very different in size and volume. So if you imagine that these are stones, clearly the pillow on the left is much larger, right? But if you line them all up, the linear dimension could be seen as the same. And so you can be very misled by reading a radiology report at times, depending on what you're using the information for. So what's the best way to measure stone burden? So there's a growing number of studies that are looking at this concept across a variety of different outcomes. Today we're going to focus on spontaneous stone passage. But this study in 2016 suggested that stone volume is better than using the maximum stone diameter to predict passage. And they essentially just used a formula. So the urologist, just like you'd measure the stone, instead of measuring one dimension, they just looked in all three views and they measured all three dimensions and put it in a formula. Take it a step further, Gendelberg study used an automated measurement. So rather than leaving it up to the urologist or radiologist, they just automated the measurement. And they found that it was equally accurate when compared to the radiologist, but more precise. We'll come back to that. But basically, they looked at 3 different radiologists, and all 3 measured different dimensions. So the average of the 3 radiologists matched the volume. But you can imagine if you took just one radiologist, there's variability there. And then finally, Sri Sivalingam at the Cleveland Clinic has done some work in this area looking at basic ellipsoid formulas versus an automated algorithms versus water displacement, which is sort of the standard of how you measure volume, and found that they were all very effective and correlated well. So just back to this point for a minute, if you take 3 radiologists measuring the same stone, this is a very small stone admittedly, but the range you can see, one of them measured it at 4 and one measured it at 6 millimeters. So for proximal ureteral stone, this institution has this nomogram for predicting likelihood of passing a stone. And so you can see just that variability in the read from the 2 radiologists gives this patient either a 75% chance of passing his stone versus a 10% chance, right? So that's a pretty big deal if you're counseling them in the ER or about management options, to have that much variability based on, and we all know trying to read stones, of small stones in particular, can be very subjective. So automating measurements may solve this problem. So the program that we used, the Mayo Clinic has developed a software called the Quantitative Stone Analysis Software, or QSAS. It's free. It's available on their web. And essentially you just feed in any CAT scan data from an IMPACS or a DICOM system, and essentially the only thing you need to do is paint the kidney. So you just have to draw this big green mark over the kidney to help the computer understand, the right density it's looking for where the kidney is. Once you've mapped the kidney, you just hit the run button, and it'll essentially look through that entire area and identify any hyperdense and consistent with a stone. And so you can see it maps the stones. You can see this stone is one shape, and then the next stone it finds is markedly different in its shape. The output that this system gives you, it gives you a stone volume, and then it also gives you a maximum linear dimension in all 3 axes. And I think the cool part about this is it gives you the maximum linear dimension independent of the 3 views that you see on the CAT scan. So again, if you have an axial view and your stone is oblique to that, the radiologist is only going to measure, or you'll only see a slice through it, whereas using automated software can actually give you the true linear dimension in the plane of the stone, which may be different than the CAT scan. This software uses what's called an adaptive threshold method, which essentially just enables it to tease out stones of different Hounsfield units. So whether you have a uric acid stone, it can identify that. If you have a stent next to the stone, it can distinguish the 2 so it won't get confused by the stent. And also finally, and really important, is it can use a 2 to 3 millimeter CT scan, which is a typical scan that we use. Some of the software that's been described in the literature uses 1 millimeter cuts, which is not typically performed at many institutions, and obviously there's a little bit more work involved there. So our aim was to evaluate whether program estimated stone volume produces better spontaneous passage predictions compared to either program estimated maximal diameter or manually measured. We had a sub-hypothesis that probably larger stones would be more pronounced in this prediction pattern. So we did a retrospective study through our ER over 3 years of all patients who presented with acute renal colic, who had a single kidney or ureteral stone. We generated information about that stone from for the manually measured dimension was taken from either the radiology report or we measured it ourselves. And then we used our outcome as spontaneous stone passage at 2, 4, or 6 weeks. And this was really determined by patient-reported passage or absence of resolution of symptoms with a definitive CT scan. So we in total had 172 patients, of which 71 spontaneously passed their stone within the 6-week mark. The cohorts were pretty similar in terms of demographics, gender, prior history of stones, laterality. I think some things to call out, obviously, this may make sense, that the spontaneous passage group, the stones were smaller, right? So that makes sense. So the average radiology measured stone diameter was 4 millimeters versus 8 for the patients who didn't pass their stones. And likewise, volume was the same. Interestingly, the location did play a role. So the patients who passed their stones were more likely to have distal ureteral stones versus proximal. So size for size, location also matters. This is just a visual format, but the patients who did pass their stones in blue, you can appreciate on all three metrics, whether it was manually measured size, program measured diameter, or stone volume, the ones who passed their stones were decreased. Interestingly, the volume was a significant fold, it was almost 8-fold difference in volume. We did an ROC analysis and found that volume had a very well-fitting curve with an AUC of 0.92, which in the literature is fairly high compared to some other studies. And this was looking for passage by 6 weeks. We picked 6 weeks because in our institution, by the time we can get a patient scheduled for surgery and treated, it's around 4 to 6 weeks on average. That was part of the impetus there. So interestingly then, if we looked at the subgroups of proximal versus distal, you can see that the stone volume was really a better predictor for stones that were in the proximal ureter, and that was at 4 weeks or 6 weeks, when compared to just linear dimensions. And so we hypothesized, because we saw that the larger stones tended to be located in the proximal ureter in the non-passed group, we thought maybe there's an issue with size here. So we did a cut point analysis, which found that the best sort of place to split the group into two cohorts would be with a size cutoff of 6 millimeters. So we then did a subgroup analysis to look at stones less than 6 millimeters or greater to see if there's any additional prediction. And so we found, first off, that the ROC, the curves, the volume still was a better predictor for both cohorts. Interestingly, for stones that were greater than 6 millimeters, both the computer-generated data sets, whether it was stone volume or the program-derived linear dimension, were more accurate than the manual measurement. And we'll come back to that. But it suggests that for larger stones, there's more subtleties in the size, perhaps, that we're not able to see or capture on the single view that we're seeing on the CAT scan. Really interestingly, though, if you look at the stones that are less than 6 millimeters, you can tease out who's likely to pass those stones based on difference in volume. But more interestingly is in the larger stones, greater than 6 millimeters, there's a significant difference in volume in those who pass or who didn't pass the stone. So what that would mean is if you see a patient in the ER with a stone of 7 millimeters, adding volume as an additional metric to your analysis will further help you stratify whether they pass it or not. So if you have a 7 millimeter stone that has a very low volume versus a 7 millimeter stone with a high volume, that can be very significant in helping you predict if they're going to pass the stone. And then we also did, I don't have it here, but we did what's called a net reclassification analysis, which basically is a way to measure, to say if you add stone volume to linear dimension as an additional predictive tool, does it add value? And during that analysis, it actually added a significant additional predictive component. So that just helps show that, especially for larger stones greater than 6 millimeters, adding volume to linear dimension can enhance your ability to predict passage. Just to call out one other finding we found incidentally, there's a large variability in radiology reports. This is just at our institution, but coming from outside as well, the diversity of reports was fascinating. So, 78% reported a stone size in 1 diameter. 17% reported 2 dimensions. 3% didn't mention stone size at all. So you get a patient with a staghorn calculus or a patient with obstructing stone and severe hydro. But it's just the variability in reports really emphasizes currently the need to look at the images ourselves. And you can imagine if you had an automated system that would run as part of this report and give you the stone dimensions and volume, it really could help alleviate some of the missing data. So in conclusions, software calculated stone volume in our model was a better predictor of stone passage than linear measurement alone, especially in patients who had larger stones greater than 6 millimeters. If we had to hypothesize why this makes sense, like we said, the larger a stone gets, the more chance it has for branching and having differences in its shape. We are doing work right now looking at this, our PCNL cohort, and we're finding preliminarily that same fact, that the larger the stones, the more nuances in the volume, and that can help predict surgical outcomes and stone-free outcomes. More importantly, I think computer-aided stone management may be a useful tool to standardize radiology reports. So this isn't this is not to say that the QSAS system we used is the end-all and be-all, but I do think having some form of automated measurement system that can augment radiology reports that's easy to run. You can imagine in this case, if the radiologist, while they're doing their report, if they just highlight the region of interest of the kidney and then run a software like this, it can generate an additional amount of information that could be useful for us in predicting information about stones. And also the issue with variability amongst radiologists. And finally, so I think obviously this is an early study. Prospective studies are warranted to evaluate the utility of volume, and particularly in these cohorts with larger patients or in obstructive stones in the acute setting. Thank you very much.